Good morning, afternoon, good evening, everybody. Welcome to another special episode of CPS VMR with POCUS today. I'm so happy to introduce our guest today, Dr. Benjamin Galen, who will be presenting the case and also teaching us some point-of-care ultrasound. And a little bit about Dr. Galen. He's an assistant director and associate program director of ultrasound and procedure training at the Einstein Montefiore Internal Medicine Residency Program and editor-in-chief of POCUS Journal. So I'm going to ask Dr. Galen to introduce himself and just tell us a few things about himself.
Thank you so much for having me. I'm really excited to be here. I've been using point-of-care ultrasound, learning and teaching it for the better part of 10 years. And I teach with colleagues at SHM and ACP nationally. And I also, like I said, I do local training. And for me, I think this is the overlap of, clinical reasoning and POCUS, two of my favorite topics. And so I'm excited to share a case with you and learn from your insights as well. So thank you for having me.
Awesome, great. And I also see Dr. Restrepo and Dr. Patel, also two point-of-care ultrasound teachers that also teach at SHM, ACP, and I've happened to bump into, actually I did see Dr. Galen at one of the meetings, but at that time, I guess he didn't know about me, but hopefully we'll see you at one of the next international or national meetings. So Shema will co-discuss. So I'll have Shema take a stab at the first aliquot, but we can launch the whiteboard. Okay, Dr. Getting the first aliquot.
Let me see. Here we are. So we have a 69-year-old gentleman who is presenting with syncope.
Shema, you want to start with that?
Okay, so when we think of syncope, basically we always think of the 6S as we learned. So transient loss of consciousness, this could be syncope. Also think of mimickers like hypoglycemia that can cause it. Also think of stroke. Also abuse of substances, also some kind of sleep. And when we think of syncope, we also learn from the great schema of the CP solvers. It could be things like a reflex, like, and also think of orthostatic things like orthostatic dysregulation, and also think of cardiac issues, something like arrhythmias. Yeah, so this is actually the basic approach that I have. And also when we think of reflex, I remember I think we have some prodromy if we think of that. But yeah, that's the basic approach. What do you say, Ravi?
Yeah, absolutely. I'm right there. I love that 6S. It was interesting. Was it 4S that was initially presented in one of the VMRs, and then we expanded. Actually, Ravi added, I think it was sleepiness, and actually Dr. Restrepo added substances, so that became 6S. So I remember that VMR with Dr. Restrepo. So yeah, actually beyond that, I think like you mentioned, physiologically, a physiological approach, so that the heart, circulatory system, and then you have other causes such as you may have pulmonary embolism, you may have, like you mentioned, substances and things like that could potentiate syncope. So I guess with more, at this point, it's difficult to pinpoint, but the age 68, I would worry about cardiac causes. So in a younger person, you always worry about arrhythmias, devastating arrhythmias, or congenital heart disease. But at this point, ACS comes into mind, definitely PE. Then other things that may also plague somebody at this age, there could be volume issues. So volume's a big one, orthostasis, and also medications. So medications can also accentuate the orthostatic issues. So definitely at this point, a few thoughts, but we'll expand our thoughts as we gain more knowledge through the aliquots.
Excellent. That's really, really helpful mnemonic and a great starting point. So this gentleman has a history of hypertension and a history of hypertensive cardiomyopathy with historically an LV ejection fraction of 35%. Without giving more history, I'll say that in terms of HPI, 2 weeks ago, there were some medication changes. There'd been a history of not always keeping up with the medications, but it had quite a few elements of guideline-directed medical therapy sort of resumed at once. So I can wait to get into some of those meds a little later. But I think the next HPI sort of detail is really that he hadn't been taking his medications, and he took all of them on his way to lunch. So he was at lunch and was seated and felt like he was going to pass out, and felt clammy, and then slumped over to his right side.
Jayma, what do you think?
So what I think is basically seeing that he has a history of hypertension, and that he's not compliant, that he also sees. I have to say, I remember the great case of Rabi when we were talking about press, actually. So a complication when we have like this posterior reversible encephalopathy syndrome, and hypertension is one of the big risk factors for it. So it can cause vasogenic edema in the posterior hemispheres, and seeing that he also had a seizure, which is also very common symptom for that, is also one thing that I keep in mind. And also when we have hypertension, also keep in mind that these people are an increased risk for bleeding, like intracranial hemorrhage. And also, like, if we think of hypertension-induced bleeding, we often think of the bleeding in the region of the telemi. So not telemi, the basal ganglia. I forgot the term in English, but and also seeing some and he also has a cardiac disease. So with an EF of 35%, making me concerned whether there is some ischemia due to lower perfusion of the brain. Yeah. These are my first thoughts.
Yeah, absolutely. Yeah, that I think the LVF was 35%, Dr. Galen.
Correct. Yeah.
Okay.
I'll add the additional history that he's unresponsive. There was no noted arm movement, or limb shaking. His eyes were closed, and then he regained consciousness after EMS was called.
So this seizure-like episode, definitely that brings into consideration, could this be a primary seizure, but this could be secondary seizure. Of course, like Sam had mentioned, that hyperperfusion could trigger, syncope can trigger a seizure episode. So we shouldn't get sidetracked by this. But at this point, LVF of 35, Shane actually correctly focusing on, that really brings to mind all sorts of different contributors. So LVF of 35, and particularly not taking medications, especially those guideline-directed medical therapies, all sorts of arrhythmias can be at play. So VTAC, VFib in this case can definitely happen. And LVF to 35%, they do particularly warrant a AICD placement or a life vest in the interim period. But when I look at cardiac causes of syncope, you either have a structurally abnormal heart or structurally normal heart. So we're dealing with a structurally abnormal heart. So things can come into play, like cardiomyopathy that could be infiltrative. Could there be something in the background? Could there be valvulopathy? Could there be ischemic injury, like Shane mentioned? So many different things come in. What about a structurally abnormal heart? All these sort of arrhythmias, long QT syndrome, and it was mentioned that some meds were changed. So maybe some meds piled on that could have prolonged the QT syndrome. But then other things come in, like Brugadas and HOCM and WPW, atrial fibrillation we do see with RVR. That can also trigger a cardiomyopathy. So at this point, it's still very broad. We don't have enough information which direction to go with, but we'll see with the next aliquot if it makes things or brings a little bit more clarity.
Yes, what a great broad differential. And that's so important in syncope, given the range of sort of more benign causes. You mentioned, orthostatic, contribution, volume depletion causing syncope. That's easy to treat and correct, to more life-threatening causes like arrhythmia. I will say that he didn't seize. I see in the box there, that he passed out, and syncope was noted without, rhythmic movement or overt seizure activity. So there was a little bit of confusion as he waited for EMS, but I didn't want seizure to take over the thread here. So let me give you some of the medical history then. Is that the next aliquot? You have a great list growing. He has CKD stage 3B, which is baseline creatinine around 2.2. There's a history of presumed hypertensive cardiomyopathy. I mentioned he's never had angiography. And there's also a history of a cerebellar hemorrhage that's part of the history that was 4 years ago without further details. I'll just give you the medications
sure,
here. We already mentioned.
Sure, if you can add those.
Yeah, that he refilled torsemide with 60 milligrams BID, aldactone 25 daily, hydral and Imdor at 50 TID and 60 daily, respectively. And there's a question about Coreg 25 milligrams, carvedilol BID.
I think I'll comment on the meds here and some of the HPI. I guess I'll start and then Shema fill in any of the blanks that I may miss. But particularly, it's interesting when we take the past medical CKD stage 3B, this does impair clearance of any medication. So we should consider with meds what could potentially stack up if there's poor clearance, especially now if this patient has an acute kidney injury on top of chronic kidney disease. So torsemide should not, but could be volume depletive, and as in the schema or build up to workup of syncope, Shema had mentioned volume depletion, orthostasis could definitely be a play here, but hydralazine, carvedilol could devastate the blood pressure. So LVF of 35%, you may not have as high a blood pressure, and this could also pull down the blood pressure pretty low and be responsible for the syncopal event. Carvedilol is renally cleared, so many times I've had patients come in with beta blocker toxicity and have bradycardia. That's possibly another cause. We were filtering through all the arrhythmogenic causes or arrhythmias, and bradycardia could potentially cause syncope. So a couple of considerations now. That's very interesting. Shema, you want to address this history of cerebellar hemorrhage? You correctly had thought about structural CNS disease. This is interesting. What do you think?
Seeing that he has a history of cerebellar hemorrhage makes it also likely for me that he may have also now an intracranial hemorrhage. So yeah, so I think that because hypertension is one of the very common causes for it. And what I also wanted to mention, seeing that he also has a past medical history of chronic kidney disease, what I think is in terms of things like altered mental status, we also know uremia can lead to encephalopathy-like syndromes, and also think of like these cardiorenal syndromes that a chronic kidney injury can have toxic effects on the heart, and also vice versa. So just as a mechanism, and also for the medications, I was thinking whether use of the diuretics maybe could also lead to volume depletion. So yeah, these are my first thoughts. And also seeing the hydralazine, I mean, the only thing that I associate with hydralazine is, like, I know it can be associated with medication induced like ANCA vasculitis, or I think like I think it can also induce a medication induced lupus, but seeing he also has carvedilol, which is a beta blocker, but it is, I think it's mainly used against hypertension, and together with the hydralazine. I'm also wondering what also the chat is saying, why he's getting hydralazine. I have to say, I always associated hydralazine as a medication for people, like women that are pregnant, that are getting this medication against their hypertension, but not in a 69-year-old male. So yeah.
That's very interesting. I just want to comment that going through the meds, you astutely had recognized what's guideline directed. Hydralazine by itself definitely is not guideline directive, and it's a medication that's 3 times daily administered and has poor compliance issues. But there is one instance where it may be warranted, as I'm forgetting the name of the trial, but the hydralazine combined with nitrates, long-acting nitrates, can actually, what they call it, Bidil, is sold as Bidil, which is a mixture of the long-acting nitrate. So in African American patients, it was found to diminish mortality and morbidity. So there is a reason for it, but here we just see hydralazine being used. So it is kind of odd as a medication to be used. And carvedilol, yes, like you mentioned, if the patient, I think somebody mentioned in the chat, is the patient eating. So patient not eating and then taking the medications will become very vulnerable depleted, especially if they're taking torsemide. And then you introduce electrolyte issues too, which could also potentiate something like this. But carvedilol is thought to be probably the best beta blocker. There's 3 guideline-directed beta blockers that are recommended. It's metoprolol extended release. On step 2, they always like to ask you that. Bisoprolol and carvedilol has many attributes which make it a wonderful beta blocker, such as free radical or diminishing free radical formation, ventricular remodeling, and also decreasing myocardial oxygen demand and decreasing the heart rate, which helps for cardiac output. Dr. Galen, back to you.
Yeah, I would add he was on Imdor 60 daily. I think I went through that pretty quickly. So he was on Imdor and hydralazine, I think, in lieu of an ACE inhibitor ARB or Entresto, given the renal failure, the chronic kidney disease. So our next aliquot, there are no allergies. His family history is not contributory here. The key parts of social history for him in terms of health-related behaviors, he's a social alcohol user, not frequently, is not a smoker of tobacco. And yes, I see in the chat, Imdor is as an isosorbide. Yeah, sorry, using brand names. Forgive me. And would we move on to exam now? So this gentleman is in no distress in the emergency department. His blood pressure is 120/78, heart rate of 81, respiratory rate 18, and he's 95% on room air, afebrile 98 degrees Fahrenheit. How does that help with some of these very broad, differential findings? Just the vitals take in any direction.
Shema, what do you think?
Well, now seeing his vitals, like we were thinking that he is not compliant, but seeing that his blood pressure is low, so makes me doesn't make me think that he's not compliant. I mean, for a 69-year-old male, that is in my opinion a low blood pressure. So I would still what was also assumed in the chat, that we should also think of interaction of several medications being responsible for his syncope, and seeing that he is afebrile makes me less concerned of an infection that could lead to his kind of altered mental status. But also seeing his respiratory rate is 18. I mean, the upper limit that I remember that seems to be normal should be between 12 and 15, and 18 is, in my opinion, a little bit high, but he has a normal oxygen saturation. Yeah, so my direction is now more on medications. And yeah, what do you say, Ravi?
Yeah, absolutely. A good observation of the blood pressure and the respiratory rate. Yeah, the 95% patient is not normal, but is a little, I guess, on room air. So the SpO2 is a little diminished, but not severely. But the heart rate is 81. Interestingly, with being on carvedilol, the heart rate should be controlled. Ideal heart rate that the carvedilol should be titrated to should be 60, 70, somewhere around there, up to 70 for congestive heart failure or chronic congestive heart failure patient with cardiomyopathy. So at this point, does afebrile rule out an infectious etiology at this point? Could there be a superimposed infection? Not really, because patients can actually have a patient without a fever and having infection actually I'm more worried about. But I'm going to put that on the back burner because right now I think with the syncope, I'm still worried about what is going to acutely be life-threatening for this patient. So ideally getting EKG, possibly getting an echo because this patient, the guidelines for getting an echo in a patient like this would be, are you worried about structural heart disease? And the patient has pre-existing structural heart disease. So getting an echo is very important as well. Chest x-ray, and do we have to entertain possible PE in this patient, and also getting cardiac enzymes, and then work our way through that, and then on to other possible thoughts. And also getting orthostasis, orthostatic vital signs at the get-go. Dr. Galen?
Yeah, I like how you mentioned relative. I mean, the vitals are not life-threatening, but in terms of relative to what his baseline might be, the blood pressure could be very low, or the heart rate may be relatively abnormal for him. So, his exam is also, I think, really helpful for your differential. He's well appearing. There was no JVD noted on physical exam. S1, S2 is regular without murmur. As long as we're clear, abdomen was soft, non-tender, no edema in the lower extremities, and it's alert and oriented ×3 with non-focal neuro exam for the medical neuro exam. It's a pretty normal physical exam.
What do you think, Shema? Does this help us?
I have to say, like, it makes me no less concerned. That could be like something like a decompensated like insufficiency, like he has a normal JVD, and also pulmonary seems clear. Like I would have like if he had an infection, I would have expected crackles, and also seeing I mean, I have to say, where are things that I wanna rule out, like as you said, we still haven't excluded arrhythmia, so I would still like to perform an EKG for this. And also generally for the medications, I would still want to perform a general urine toxicology to see how it is, and also also a heart echo to see, like, as we have seen, his EF was 35%. So I want to see could there be any kind of pericardial effusion that we haven't seen, or could his yeah, I mean, these are the basic things that come into my mind, but I have to say I'm still very open for everything.
A number of really great thoughts there again, Shima. I like the part about pericardial effusion. So what's interesting is it's a dynamic process. So patient may not just come with all of what we learn about Beck's triad, but it ramps up, it transitions to what you get with Beck's triad. But I've had patients pass out with just hypotension, and how heart sounds was there, didn't have the tachycardia and so on. So that definitely still could be at play here. What's interesting with the heart rate 81, we were very much hell-bent on possible arrhythmia, but arrhythmia is usually, I would want to see a very fast heart rate, but you can have arrhythmia. Say you have a new onset of AFib with slowed ventricular rate. What does that mean? That means there may be an abnormality in the conduction system. But again, the heart rate 81, that's one heart rate in a number of many heart rates. When you're seeing a patient in the hospital, this 81 could be a snapshot in time, but the next heart rate that they take, it could be 40, it could be 30. So I'm still very worried about conduction disease, but there still could be arrhythmia because that heart rate could very easily jump from 81 in a paroxysm to 120, 140, 150. So there could be definitely an arrhythmia at play here. Dr. Galen?
Yeah, I think the exam and the vitals, he's not overtly decompensated from the heart failure standpoint. You mentioned valvular disease, and to the extent that critical aortic stenosis, severe AS could be hemodynamically significant. We don't hear a murmur, which, as you know, the murmur of severe AS can soften as it gets more severe. So that isn't ruled out, but that's not screaming out at us. And then again, the acute decompensated heart failure doesn't tend to present with syncope. So the fact that he looks euvolemic or not fluid overload by JVD, by his lung exam, by his lower extremity exam, that doesn't really rule out hypovolemia, but it certainly doesn't seem that he's acutely decompensated. So
actually one observation that is something that just you triggered a thought in my mind. With the low LVF, we usually look for, I've had many patients come with syncope and have critical aortic stenosis. But what if you have an LVF of 35% and you have mild or moderate, and you're not able to get that squeeze through that bottleneck of that tight valve, or moderately tight valve? So a lot of times in compensation to critical aortic stenosis, you get LVH, and you're able to have that pressure gradient across the valve. So the way you diagnose critical aortic stenosis is the valve surface area, the transvalvular gradient, and there's also velocity, flow velocity across the valve. But I've seen patients with low LVF, their mild, moderate becomes severe because they're not able to eject that blood across that pressure gradient.
Right. It's a great point. He is under the care of a cardiologist, presumably has had more recent echoes. We know the progression of AS historically, over time. So if he'd had prior echo history that I gave away, that might help you with your reasoning. But why don't we jump into the labs? Here, I can give you the basic, you want the CBC. So his, let me see here. His white count is 7.8, hemoglobin is 14.7, hematocrit 47.1, and his platelets are 151. And I'll just give you the chemistry here while we're at it. Sodium of 143, potassium 4.6, the chloride 99, bicarb 28. His creatinine is 3.82, and the glucose is 128. BUN 57.
What do you think, Shima?
So now seeing, so basically in the hematology, that seems unremarkable. So his platelets with 150,000, it's just at the border, but it seems okay to me. So he doesn't have any kind of anemia that would also make me concerned. And also now looking into the basic metabolic panel, I don't see any abnormalities with the electrolytes. So making this bucket of electrolyte imbalances being put aside. His glucose with 128. So the question is for me, when did they measure it? And also, like, does he have any kind of history for diabetic issues? As we also know, I mean, like, this glucose is still okay to me, like especially for an older male, but also consider that hypo or hypoglycemic states can also always be encountered with syncope, but not now in his state. And now seeing the creatinine with 3.82, as we have seen in his baseline was 2.2. So I'm asking myself in which time course did his creatinine rise. So I'm still not ruling out uremic encephalopathy-like syndromes. And yeah, this is my basic, these are my basic thoughts. Yeah. What do you say, Ravi?
Nothing to add there. Wonderful walkthrough of all the labs. Really don't know how I can incorporate a lot of this except for the renal function. But yes, Shima?
I mean, the only thing that I also associate when we talk about uremia, I know, as we know, uremia can also cause something like pericarditis. So yeah, it would be very interesting to me. So looking into the EKG, do we have, I mean, like, for pericarditis, I would also, sometimes we can expect, I think, also pain, chest pain, but we could expect several features in the EKG to see whether we have like diffuse ST elevations, do we have PR depressions, and yeah.
That's a great thought. Yeah, pericarditis, especially, you don't always, I always thought you hear the rub on examination, but it's intermittent. I've heard the rub, then I've gone to grab people, come listen to this rub, and then it's gone, and they're like, there's nothing there. So it can come and go, and that's something you definitely will look for. And the EKG findings, you did a great job there. Yeah, the PR depression and ST elevations, definitely a hallmark of pericarditis. Dr. Galen?
I think that's a great point. The differential here for someone with chronic kidney disease who has a progressive renal failure into the syndrome of uremia, the BUN is not really in the range where we'd necessarily expect that. And I think knowing the baseline several weeks prior, I think I mentioned 2.2 was closer to the creatinine baseline, the BUN closer to 30. That's probably not in the it's more of the timeline of an AKI than progressive CKD, which is not typically associated with effusion. But I think when it comes to very quick goal-directed binary questions, POCUS is great here, as a tool to answer that question very quickly. Is there a pericardial effusion present or not? And it's a great thing to always think of when you grab the ultrasound. What are you looking to answer quickly in that fashion? As far as the LFTs, they're normal. The albumin's normal, and the liver tests are normal. I can show you next. Everyone's very excited for the EKG. Would you like me to share my screen and show it to you in addition to providing my interpretation, or what do you think?
Sure, that'll be exciting.
Okay. So if I can pull it up, let's do that. Share screen. Oh, don't look at the rest of the PowerPoint. Close your eyes, quick. Okay, phew.
So should we start with the interpretation?
Sure.
Yeah, Shami, you want to try? You want to try looking at it?
Okay, I try it. So I first look into the leads 1, 2, and 3. And the first thing that I always do is to see whether we have sinus rhythm. And I see a P wave in front of every QRS complex, and looking into the distance of the R's. So I see the distance is always the same. So I can actually say that this is rhythmic. And also, and now looking into I see that this is a, let me check, an overt left axis deviation. I mean, I'm not very keen with the English terminology, so please excuse me if I say anything wrong. But what is also looking that we see that I would say that he is tachycardic, but we have 25 millimeter per second, and if we look into the distance, oh my god, I'm so bad with assuming the okay, yes, he's standing 150 is his heart frequency, so yes, he's tachycardic. And now also looking into the in V1 to V6, so I see that there are some negative T waves, but these are pre-terminal. And when I think of negative T waves that are not concordant with the QRS, I assume something like an ischemia. And otherwise, he has very high R's of the QRS, making me also concerned of something like a left ventricular hypertrophy, especially seeing it in the left precordial leads. And there's also thank you, Leah, for mentioning the left anterior hemiblock, because we can see that there's an S persistence in V6, and usually we shouldn't have a permanent S in the V6. And so if with the marked left axis deviation together with the S persistency, we can say left anterior hemiblock. But yeah, I would stop here and give it to Ravi.
That was a superior reading. That was phenomenal. Yeah, I definitely picked up the ST depressions in the lateral leads. I also look at one in AVL, so it's geographically related, but the problem is it may be contributed by the LVH that you picked up. So there's various ways you can calculate. I use the SDS4, so the S in V4 and the deepest S in any of the leads. So V3, 28 in males, 20 in females. It's like a new way of calculating it, the Presti-Perez rule that you can use. And there's other ways of using it, Cornell and so on. So those ST depressions, I'm not sure if they're due to strain pattern or repolarization abnormalities, but are we correct, Dr. Galen? You did a great job on that.
Yeah, wonderful job. I just want to correct one thing. The heart rate, his pulse was 80, and I think, you can count the boxes and multiply, but it is around 80 for the heart rate. So yeah, sinus with LVH, left axis deviation. Also some atrial enlargement, maybe left atrial enlargement. You can see the P mitrale pattern perhaps. And I think the key here is that the repolarization that you're noting is not new. This is really unchanged from prior EKGs. So that's not, I don't have a comparison to show you, but that the LVH with strain pattern is probably more consistent with the clinical history. All right, so his, let's see if I can go, his chest x-ray was provided.
What do you think, Shema?
So looking into this, I would say that does it look like I mean, like when I look, basically the heart silhouette looks very enlarged, because usually if we look into an X-ray, the heart silhouette shouldn't take more than 50% of the diameter here, and so it is more than 50%. So, and also I would say we see some prominent highly, prominent highly, and otherwise also I think the aorta also looks a little bit prominent here, and the heart looks a little bit like a boot-shaped heart. But otherwise we can exclude fluid, because we see that the recessi are there is no fluid, and also otherwise, I don't see any form of abnormality and no sign of a cardiogenic edema. Yeah, what do you say?
Awesome, Shema. Yeah, I was ticking all those boxes. The hilum stands out to me. And then there's, if you follow, you see the aortic knob, but then you see this outline, this opacified sort of outline going down. I don't know if it's the esophagus, but something there that, that edge there is outlining something. I do see some tracheal deviation up top. So if you follow the trachea, it's a little pushed to the side. So do we prioritize anterior superior mediastinal phenomena that could be pushing the trachea? Could there be thymus, so on, so the terrible T's? But then there's this other opacified structure that is being accentuated here. So I am not quite sure what that could be. Could that be a large esophagus? I doubt with the aortic knob. Could it be a dilated aorta? But that you could put that in the differential. A CT would help, or other imaging, ultrasound might help narrow down the focus on this. Dr. Galen?
Yeah, I appreciate how detailed you are looking at the X-ray. I actually hadn't noticed that finding. I'm not sure if could be some kind of artifact, in a way, because it's now that you say it, I can't look away. But I had noticed that before, and as well, you're so systematic and thorough. It's wonderful to see how you approach it, and that tracheal deviation I see now, but I was not apparent to me at the time. So this is real life. So I'll let that stand. But I think we should get into maybe the next aliquot. Is there do you want to share your screen again, or let me see if am I missing anything, or should we jump into some of our goal-directed questions?
We have the whiteboard.
Okay. Is that that is the final aliquot. All right. So yeah, I think the case overall and such a wonderful differential, integrating the physical exam, the labs, and all with the history. I think that it really begs for a point of care ultrasound exam, because we know they're clear lungs and a clear X-ray. So maybe the money's not on a chest ultrasound. But I think that the volume status question in someone with a history of systolic heart failure is always appropriate. And so taking a look at the basic cardiac POCUS as the next integration is really helpful. And I think you guys had a lot of questions that you wanted, basic binary questions from cardiac POCUS. So I can share my screen again And let's take a look at that image. So make that a little bigger. Just let me know if this is playing okay.
Yep, it's playing well.
So what are some things we were thinking about on our differential that we can kind of quickly cross out here?
So let's see a parasternal long axis, and then going through last week, Dr. Gigi Liu did a great walkthrough of the rule of threes. So looking at the right ventricle outflow tract, the aorta, and the left atrium, seeing if they're the size is equivalent or if one is larger than the other. Appears looks pretty proportionate. Looking at the aorta, I don't see highly hyper, I get echogenic sort of aortic valve, not looking very hyper intense. That's the correct word. So it looks less like if there's a valvulopathy there. But what really stands out, I'm just looking at the ventricular walls, looking in the chat if anybody puts in anything, but the ventricular walls look massive, actually, very, very thickened if you think about it. And can't see, let me see the mitral valve. I do see it, yep, right there. I don't see any issue with it, no. Unless we have color flow across it to see if there's any regurgitation.
Right, and that's a great point about the limitations of just basic cardiac POCUS. You're not really able to answer more advanced questions like about regurgitation. That the visual coaptation of the anterior and posterior leaflet here doesn't rule out eccentric MR that might be clinically important. So that's not part of the basic B mode cardiac POCUS exam. I think for stenosis, it probably is more helpful. You can see that the aortic valve is opening in appropriately. I think in systole it's could there be mild AS? Maybe, but in terms of the question you had about either the reduced LV function from LVH, could that be worsen the physiology with AS? It's probably not a case of AS looking at this. As far as the rule of threes, it's not just, I think, size is one thing, but thinking about function is another. So the RV outflow tract really should contract well, throughout systole, and you should see that the RV free wall is coming in. It isn't always vigorous in someone with IV failure or pulmonary hypertension. There may not be vigorous contraction, but it looks probably large to me. The time it takes to measure is not really ideal. Just a point of ultrasound is not really about taking that time. It's about saving time. So here, this looks probably visually a little bit generous. It's a bit of a bully, hogging more than it should. If you think of the LA and the aortic root, 3 centimeters normal size, the RV seems to be a little generous. But you're right, as far as finding of LVH, it's suggestive. We don't tend to call that on or grade that on POCUS exams, but what pericardial effusion really not seriously present. Maybe in systole you see a small effusion, but we talked a lot about uremia. This anterior space can be a little bit echogenic, which is anterior fat can do that. That is not always clear, and so sometimes beginners get a little concerned about whether there's effusion here, but we have plenty of other views to assess that. And this is descending aorta, no obvious enlargement or dissection or something like that. So a couple life-threatening things ruled out. You'd mentioned in the differential, here as PE. I think that's not ruled out here. One of the other caveats for the parasternal long is a great starting view, but it doesn't tell the whole story. So if you see a very large RV outflow tract that's not contracting well, that could catch your eye, and then you follow it up. But seeing that was normal doesn't rule out submassive or massive PE physiology or decompensated RV otherwise. It's a lot, but let's continue. So let's take a look at the short axis. So tell me what you think about this.
Yeah, if I'm seeing correctly, on the left side, the right ventricle does look larger. And I do see the intraventricular wall collapsing towards the left ventricle. So it almost looks like this D sign. Is it? Would you call it that?
Yeah, the Sesame Street, brought to you by the letter D. So as you pointed out, the normal parasternal short has a circular, LV with an RV that's not quite as generous. It really is prominent here, but a normal parasternal short at the level of the pap muscles has a circular LV. So this in systole and diastole, we see that this is flat. So how does that integrate now? What are you concerned about?
Shema, what do you think?
So in terms of the D-stem, we right ventricular, if the not can we say decompensation? So when I think of it, it's like if we have something like acute pulmonary embolism, because usually we know the left ventricular is much larger than the right ventricle. Yeah.
Right.
Oh, sorry.
No, I was going to just add that really the easy way to think about that is that the LV EDP is probably higher than the RV EDP, which is the RA pressure if your tricuspid valve is cooperating. In order for this to happen, the RV end diastolic pressure has to exceed the LV, as well as the RV systolic pressure has to exceed the left side to be able to have that physical push. So I think integrating it with this could be acute on chronic, this could be chronic, or this could be acute as a finding, really. But the rest of the physical exam should help you in terms of thinking about how concerned you are about this. In terms of there's no history of pulmonary hypertension and there's no right-sided findings, there's no congestive hepatopathy on the labs, there's no lower extremity edema. So this would be concerning, for acute decompensated RV.
Absolutely. I think in the chat they asked for BMP troponins.
Yeah.
And probably the patient does have kidney issues, so VQ scan would be imperative at this point.
Yeah, sorry, I've been looking at the chat. The BNP was elevated historically and also persistently elevated. The troponin was negative, not zero, but below the cut point of at the time of the lab assay here. So no, the BNP was elevated a little bit above baseline, and the troponin was negative, ×2 actually. So let's move on. The IVC, everyone is interested in the IVC. Clearly has to be integrated with the other cardiac POCUS, as well as your other elements, the volume exam, your chest ultrasound, as well as physical exam. So what do we see here?
I would say the IVC looks dilated. I mean, usually I would expect the IVC being able to collapse, and I feel like I don't really see it, and I feel like the diameter is also very large. Yeah, but
right, so
I don't have to say that.
It's suggestive of elevated RA pressure. Yeah, that's actually I think a really key point to this case, because I think you're going in thinking that hypovolemia with the medications, or hypotension was the cause of the syncope, but and he's not in acute decompensated heart failure, but the IVC is enlarged and the chest is clear. So you might find a dilated IVC without respiratory variation in someone with acute decompensated heart failure. That doesn't quite fit here. So you're thinking of other physiologic reasons why the IVC might be dilated or the RA pressure would be high. Anyone see anything else on this? This is the subxiphoid IVC view. So there's one thing that catches the eye, that this is, I think a very subtle finding, because there are a lot of echogenic elements. We know it's IVC because the RA is right here. The IVC drains directly through the diaphragm to the heart. This is the hepatic vein, but there's something flickering here. It's echogenic, bright. It could be artifact. It could be a true structure. Any thoughts about what that might be in the setting of some of the other findings? Let's take another look at it. This is intentionally off axis. So this is the hepatic vein. This is the diaphragm. This is the liver. And we see part of the IVC, but we're off axis now, seeing more of the right atrium here. This is the right atrium. So this is that echogenic structure that caught the eye. Any thoughts on what that might be?
The chat mentions thrombus, which I think Shema, yep, thrombus.
Yes, I would also say that, but the thrombus in the inferior vena cava, I feel like, isn't it much more an atypical place for a thrombus to manifest?
It could be transit on, it's propagating upwards.
Yeah, this is actually, it's in the right atrium and it's extending into the hepatic vein and the IVC. So it's not primarily in the IVC. So clot transit is a sort of a nickname for that finding. So this is a bit of a surprise, I would say, even in the typical venous thromboembolic case where you might have right heart strain on cardiac POCUS, like we noted, which is submassive PE physiology, but this is also a right heart thrombus. So right heart thrombus being a more technical name, clot in transit being more jargon used in the literature. So this is a comparison. So how does that strike you? I guess the question is, we need another hour for the management reasoning. We did diagnostic reasoning here, but management reasoning being a whole nother topic. But as far as seeing a right heart thrombus, how does that help tie the case together?
Now thinking more of something like a pulmonary embolism, like a transit emboli that has maybe caused an acute pulmonary embolism, because we had discussed that he actually didn't have any prior history of pulmonary embolism. We didn't see any kind of risk factors. So
Correct.
Yeah,
I think that's the key. Without risk factors for venous thromboembolism, this wasn't the top of our differential for syncope, but it was mentioned as a known cause, potential cause of syncope. But he has two diagnoses. It's not the existing PE was probably what happened at the lunch table, and now he has an impending PE as well. So this is a subxiphoid view. I skipped over just because it would have, I think, given it away too quickly. But we see here, this is the liver. This is the right atrium. We have part of the diaphragm, right ventricle, left atrium, and left ventricle. There's no overt pericardial effusion here. This is the best view to see that, but we see a very large echogenic structure in the right atrium. So certainly went into the POCUS thinking that we'd get a little more hint at some of the volume status exam, but we had a surprise here that's a life-threatening entity. If I may just take a minute to go into it, right heart thrombus is not consistently described in the literature because there's so many different names for it, but there's a possibility for what's called a impending paradoxical embolus as well. If the patient had a PFO, that can be very serious, rapid and fatal diagnosis. Overall, I think estimates are that in-hospital mortality for right heart thrombus is about 80%, and when treated still has a 20% mortality. So it's a high risk scenario that illustrates the power of the point of care exam. It certainly would have been picked up on echocardiography as well, but that's a time delay, and so this highlights the importance of making an early diagnosis of submassive PE and right heart thrombus. I think as you're waiting to manage this emergency, the additional POCUS that's helpful just to kind of assess the case would be a lower extremity examination for DVT, and POCUS for DVT is also just supportive of the entity of venous thromboembolism. So this is a popliteal vein with thrombus, a popliteal artery, and that is always good to know as you get into your invasive strategies what the status of the lower extremity veins are. So
incredible. This is another great case, something that we haven't seen over the course of this POCUS VMR. But I just want to make a plug, Dr. Galen. I actually had a patient that was being discharged, had a DVT, was walking the entire morning, anticipating discharge, walked down the hall, collapsed, got him in bed, put the ultrasound on, and we saw the same exact thing, a clot now in the right atrium, thrombolytics, and he survived. So very powerful tool, especially in a rapid response in a patient that's decompensating. And if you're able to learn it, we're doing a lot of image interpretation here, but if you do get a chance to learn image acquisition, it can be very powerful in encountering patients in the emergency room. So I really appreciate this great case. I definitely learned a lot. Shema, any reflections?
Yes, thank you so much. A very amazing case. I also wanted to ask a question regarding the case, like, as I understood right now, so seeing now realizing that he has pulmonary embolism, and we know he is taking medications to lower his blood pressure, and also that could affect his heart rate. For carvedilol, I don't think that it's very what was it? That it is decreasing the chronotropy of the heart, but I feel like did his medications just masquerade his symptoms of hemodynamically being unstable? Like, he has a history of hypertension, but he didn't seem compliant with his medical history. So was his low blood pressure being explained due to his pulmonary embolism, and the low heart rate due to the medications, or what was it?
Well, I think it's a little confusing. So, this is real life clinical medicine, but the carvedilol is a alpha and beta. It's going to be chronotropically active at the dose here, definitely. So I think you're right to point out he was not on maybe not compliant chronically with the Coreg, but definitely took it a dose or here in the preceding moments to his PE. So it's possible that he would have been more tachycardic had he not been on carvedilol. That I agree with. I think that in terms of the PE, he had a right lower lobe PE that was actually diagnosed on angiography. He went for mechanical thrombectomy for this. So he had right lower lobe PE, but the cardinal features that you'd expect were not there. He was not hypoxemic. He didn't have underlying lung disease. So he was able to oxygenate despite that, some element of EQ mismatch. He did have a good blood pressure despite the sort of hemodynamic hit. I think the mechanism of syncope in PE is the transient RV alpha tract obstruction, impairing LV preload, and then transient hypotension. But this clot, I think, if that clot embolized on top of the existing clot, the further decompensation of the RV would be so dramatic that the hemodynamics would not be maintained. But I do like your point that despite being on several vasodilatory agents after low reduction, that he was able to maintain hemodynamics from the initial syncope and not arrest from hyperperfusion to the coronaries, PEA on scene. He had syncope, he recovered very quickly in the lunchroom. So despite the one of the 6 S's, substances, S being what a doctor provided him appropriately, but he was able to recover. And I think that there really are no risk factors for PE here, no classic ones that would have prompted that at the get-go. So this is a humbling case of how POCUS can really change the management immediately at the bedside. This is, fortunately not that common, but we do see it, I think, more and more now that cardiac POCUS is done routinely. And so it's something that if you're going to put the probe on the chest, look at these cardiac views, you have to be aware that this is an entity that could be encountered. So don't go staring at every single little artifactual, echogenic, part of a cardiac POCUS every time. But I think seeing a thrombus like this is definitely good to keep in your mind when you're looking at any cardiac POCUS image. So
I think the only thing that I'd like to jump in and just comment on is there's an old adage in point of care ultrasound and also in like a lot of radiology, but a one view study is a no view study. And so if you had stayed on that parasternal long, you'd be tempted to think you saw that ventricle kind of coming together and that mitral valve was like swinging open and closed, right? You'd think that the person's underfilled in this case, and they are underfilled, but they're not underfilled because they're hypovolemic. They're underfilled because there's not blood that's actually making it to left ventricle from this large thromboembolic thing. So I think that's a great reminder that like, if you are going to be doing point of care ultrasound, make sure you're going to be looking at several views because one view does not tell the whole story.
Excellent point, Dr. Sharp. I really appreciate that. I think that I couldn't get away from this opportunity to just discuss PE briefly in the context of syncope. So there are two trials, the PISA trial, which argued that this was really a horse and not a zebra, that PE as a cause of syncope. But there's a wonderful editorial in JACC where the Basel 9 trial was published that compares those two databases. So PE as a cause of syncope, somewhere between 1.4 and 17% of the time. And if you're asked on rounds, always give a range, because that way you're not too far off. So someone asks you how often can PE be a cause of syncope that's not otherwise explained, somewhere between 1.4 and 17% of the time, but definitely something to keep in mind. So this case was presented in chest in the ultrasound corner, published previously. So I just wanted to point you to that. If you have access to chest, the ultrasound corner, there's some other discussion points in the published case report. So
great, thanks for sharing that. That's incredibly powerful for our learners here. I guess, Leah, should we wrap it up with the teaching points?
So I'll just quickly share my screen so that you can see the board. Or could someone who has the access share the screen? Thank you. Okay, so thank you for the presentation and also this great discussion. I think it was very interesting. We started off with just this one symptom like syncope, and then Shema talked us through the different differential diagnosis of transient loss of consciousness. So we had the S's that we remember for that. And then syncope can be further subdivided into 3 buckets of reflex syncope, cardiac, and orthostatic. And with orthostatic, we also think about medications that might influence blood pressure or volume status. And then it was also an important learning point that when we evaluate vitals, it's important to always remember what the baseline of the patient might be, because a quote unquote normal blood pressure for one person might not be a normal and stable blood pressure for the other. And then also it's important that vitals should be taken continuously if you have concerns that one might not represent it accurately because it's just a snapshot. And because volume status is so important in evaluating also syncope, because it can be a factor of how the brain is perfused, POCUS is a really helpful tool we can use for that. And POCUS has some limitations, which Dr. Galen also taught us, that the basic cardiac ultrasound is not able to rule out valvulopathies or also even major pulmonary embolisms. And it's always good to remember that one view is no view. So we should look at different axes to get a clearer picture. And then we had a few cuts of the echocardiography. We had the parasternal long axis where we remembered the rule of 3. So we look at the right ventricular outflow tract, the aortic root, and the left atrium, and evaluate these 3 to size, but also check the function. So not only look at the size, that was also April that was mentioned. And in the parasternal short axis, again, the importance of doing 2 axes, we saw the D sign, which clued us into there might be elevated right ventricular pressure. And this can present acute and chronic. And there were a few clues with this patient that made us think this might be more acute, already that he didn't have like pericardial effusions. That was also something that would fit the more acute presentation. And then always an important image to look at for volume status is the IVC. And there you look at the diameter and also the pulsatility of the inferior vena cava. And this can also, in this case, it was dilated and showed us that there might be elevated right atrial pressure. And the final thing that we saw with the ultrasound was a hyperechogenic structure, which was the cardiac thrombus, which in the end was the diagnosis also for our patient. So thank you for teaching us today, and have a nice day.
Thank you so much for having me. I just want to add one final reflection. Years out from this case, I think that syncope is so common, and causes like the vasovagal syncope epidemiologically are the most common orthostatic hypovolemic contributions, and I think those can be present, and they can be coexisting with some more serious pathology, which is why syncope is taken seriously and evaluated. And Dr. Restrepo's point, outstanding one to reflect on. You were expecting this underfilled LV to be just like the history, the medications, the diuretics, and that if the IVC had been collapsed with fully collapsed or sliver in the liver, as we call it, where really supportive of hypovolemia, that would have been sort of early closure here. The patient's allowed to have more than one diagnosis. So thank you so much again for letting me present this case and be part of your report.
Thank you, Dr. Galen. Again, the great masquerade of pulmonary embolism strikes again. So I think you really have educated everybody here, and hopefully as they gain more experience with POCUS, they can actually make a rapid diagnosis and ultimately save a patient. So a lot of downstream effects and positivity from this case, from what you've presented here. So appreciate you coming on again, and have a good afternoon, everybody. See you tomorrow.
Thank you.
Thank you.